Welcome to Dr. Balga's podcast for the Curious Doc. Today is April 3rd, 2026. This video is on a Lancet article published online first on March 29, 2026, 3-4 days ago, titled Aspirin versus Clopidogrel for Chronic Maintenance Monotherapy after PCI, after percutaneous coronary intervention, a 10-year follow-up of the host exam trial. There was an accompanying editorial titled, or commentary titled, Moving Beyond Aspirin After PCI, 10-year Results from the Host Exam Trial. Lifelong monotherapy with antiplatelet agents after PCI standard. Aspirin dominant historically. Clopidogrel, a P2 Y12 inhibitor, is an emerging alternative. The investigators of the host exam randomized controlled trial conducted an open label study in 37 centers in South Korea. The study cohort comprised of 5,438 individuals. 2,710 were on clopidogrel and 2,728 were on aspirin. Event-free 6 to 18 months post-DAPT were enrolled. Median follow-up was 10.5 years. The primary composite endpoint was death, myocardial infarction, stroke, ACS readmission, and a BARC score equal to or greater than 3 for bleeding. Statistics, intention to treat analysis, and Cox models. What did they find? The primary endpoint was 25.4 in the clopidogrel group versus 28.5% in the aspirin group. Hazard ratio 0.86, p-value 0.005. Thrombotic in the thrombosis in the clopidogrel group was lower at 17.3% versus 20% in the aspirin group. P-value equals 0.0024. Bleeding was 9.1% versus 10.8% in the aspirin group. P equals 0.02. Stroke hazard ratio was 0.72. P-value equals 0.0081. No mortality difference, hazard ratio 1.07, p-value 0.40. The limitation of the study was its open label, Asian-only cohort, post 2 years therapy non-randomized trial, and there were differences in adherence. The key takeaway was clopidogrel was superior for ischemia and bleeding, cumulative benefit over time, but there was no mortality difference. The editorial perspective challenges the aspirin dogma. Clopidogrel has broader platelet inhibition, less GI toxicity, better adherence. This is the first robust 10-year data, and these have implications for evolving guidelines. Clinical pearls. Consider clopidogrel for long-term monotherapy post-PCI, particularly with GI intolerance, reduces stroke, acute coronary syndrome, and bleeding. No mortality penalty. Individualized, there is a subgroup benefit in the CKD group. This is in a nutshell. Go to Lancet and read the article. CKD subgroup, signal or shift. In the pre-specified analysis, CKD patients showed greater benefit with clopidogrel. Hazard ratio for the primary endpoint 0.69. Significant interaction, p-value equals 0.041. Whereas in the non-CKD group, it had an attenuated effect. This suggests amplified protection in high-risk vascular milieu, potential interplay, platelet reactivity, inflammation, and endothelial dysfunction. Caveats: the subgroup analysis was not powered for CKD specifically. This is hypothesis generating, not definitive. Clinical pearl in CKD patients post-PCI. Clopidogrel may offer disproportionate benefit, a signal worth respecting, not yet canonizing. This slide is the BARC scale, or the Bleeding Academic Research Consortium classification. Hit pause and read at your leisure. Podcast brought to you by masterbedfacts.com. This podcast is for physicians and healthcare providers. If you enjoyed this video, please like, subscribe, and forward to your friends.